Welcome to the unit of gastrointestinal disorders. The disorders of the GI tract are really huge number of disorders. I try to categorize them into 4 categories: upper GI disorders, lower GI disorders, pancreatic disorders, and lastly, hepatic disorders. Let's start with discussing some of the upper GI disorders, and I'm going to be talking mainly about GERD, peptic ulcer disease, and some talk about nausea and vomiting. Let's start with this question first. A 43-year-old heavy smoker male presents with a chronic epigastric pain and also drinks 3 to 5 cups of alcohol daily. What is the most common cause of chronic epigastric pain? Chronic epigastric pain, a very common complaint. And as you see, any one of these 5 choices could be the cause of chronic epigastric pain. What do you think the commonest cause is? If you thought it was non-ulcer dyspepsia, you're correct. Yes, non-ulcer dyspepsia is the commonest cause of chronic epigastric pain. Non-ulcer dyspepsia is an exclusion diagnosis. You need to exclude all the other 4 in order to be able to diagnose non-ulcer dyspepsia. And that's why we're starting by discussing these upper 4 causes of chronic epigastric pain. And let me start with GERD, gastroesophageal reflux disease. Gastroesophageal reflux disease, the pathophysiology of it is very simple. The lower esophageal sphincter is kind of leaky, kind of weak. It does not keep the stomach content and the stomach acid from leaking up into the esophagus. And the manifestations, think of the acid moving up from the stomach into the esophagus. What are you going to feel in the esophagus here? You're going to feel heartburn. This heartburn is going to be retrosternal, and sometimes it is not just heartburn, sometimes it is chest pain. Chest pain can happen because of the irritation of the esophagus as the stomach acid is passing into the esophagus. And note, the most important time, the most frequent time for these symptoms is during night when you are asleep, especially when you eat heavy meal, fatty meal, and go directly to bed. This will increase the incidence of regurg. So the stomach acid is going to regurg through the leaky lower esophageal sphincter and will pass by the esophagus and will cause heartburn. And then when it hits your throat, when it hits your larynx, it will cause sore throat. And then when it trickles into the trachea, before the trachea, when it irritates your larynx, you're going to develop what? You're going to develop hoarseness of voice. So irritation of pharynx, sore throat, irritation of larynx, hoarseness of voice. And when the acid trickles down and irritates the carina, now you cannot help it, and you're going to be awakened with a very bad cough. Because what? Now there is an acid irritating your carina. And then when it trickles even lower down into the lungs, you are going to develop bronchospasm, and sometimes also you can feel bad taste at the back of your tongue, because the back of the tongue has the taste receptors for metallic taste or bad taste, so you're gonna have this sense of bad taste. So let me review with you the manifestations of GERD: epigastric pain, only pain, no tenderness; substernal chest pain, and the associated symptom: heartburn, and sore throat, acid in the pharynx; metallic or bitter taste, acid hits the back of the tongue; hoarseness, acid hits the larynx; chronic cough, acid hits the carina; wheezing, acid hits the lung. And remember, these symptoms can awaken the patient. Actually, they will awaken the patient from night sleep. How we diagnose GERD? Actually, one way to diagnose GERD and treat it at the same time is the administration of proton pump inhibitors. And the reason for this is proton pump inhibitors have 90 to 95% efficacy in treating GERD. So if the patient does not respond to PPIs, to proton pump inhibitors, omeprazole, pantoprazole, lansoprazole, if the patient does not respond to these medications, most probably this patient does not have GERD, or maybe the diagnosis is wrong. So only in this case you might need to do some testing for GERD. And the proper testing now is to do 24-hour pH monitor if there was no response to proton pump inhibitors. The big question and the most important question, when to do upper GI endoscopy in a patient with epigastric pain or suspected GERD. If you have any suspicion of malignancy, esophageal malignancy, weight loss, dysphagia, anemia, blood in stool, to exclude esophageal cancer. But we do not start the treatment of GERD only with proton pump inhibitors. We have to do important lifestyle modifications. And one of the most important things is elevation of the head of the bed. Elevate the head of the bed. And when I say elevation of the head of the bed, this is not equivalent to put pillows under the patient's head. Because when you put pillows under your head, all what the pillows are going to do, you're going to flex your neck like this, and you're going to end up with having a neck pain, and still your GERD manifestations are there. But when you put 6-inch block below the head of the bed, this is going to elevate the whole bed, and you are going to make use of the effect of gravity to keep the stomach acid within the stomach. Quit smoking, because smoking is one of the factors that increases the weakness of the lower esophageal sphincter. Limit alcohol, caffeine, chocolate, peppermint. All these will lower the esophageal sphincter tone. And do not eat within 3 hours of going to sleep. Separate your last meal from sleep by at least 3 hours. And the drugs, as I said, proton pump inhibitors. H2 blockers can be used, but if the H2 blockers fail, now proton pump inhibitors will do better job. Do not treat Helicobacter pylori if the diagnosis was only GERD. If it happened and you, for some reason, ordered a test for H. pylori, and H. pylori was positive in a patient who is having GERD, do not treat H. pylori, and I'm going to come to that when we come and discuss the peptic ulcer disease. Now let's discuss the case study, our first case study, GERD. The key features in this patient, now we have a 75-year-old male with a significant history of GERD, but this GERD is getting worse. And the histamine 2 blockers, cimetidine, of course we do not use cimetidine now, we use ranitidine, famotidine. The H2 blockers are not working anymore, per the patient's words. And the patient started to develop postprandial retrosternal heartburn, some regurgitation and dysphagia, and despite sleeping with 3 pillows, the patient has also begun to experience frequent nocturnal awakening from heartburn and regurgitation. The patient has positive history for caffeine intake, smoking, and alcohol, all the bad factors that increase the lower esophageal tone weakness and leakiness. Also in the past medical history, the patient has a very important, significant contributing factor to GERD, which is hiatal hernia. Hiatal hernia is kind of an anatomical defect in the upper stomach and lower esophagus. This also adds to the weakness of the lower esophageal sphincter mechanism. As for the clinical course, this particular patient, as in your case study, underwent upper endoscopy that showed evidence of esophagitis without evidence of bleeding, ulceration, stricture, or esophageal metaplasia. And the patient was treated with an 8-week course of a proton pump inhibitor, and he improved. Let's do some important questions in that case study. Question number 1, which clinical information suggests worsening symptoms of GERD in this patient? Of course, the patient himself said that the acid reflux is getting worse, and the anti-reflux medications, the H2 blockers, are not working anymore, and the patient also reported increasing episodes of heartburn after eating, and the patient started to use antacids in addition to H2 receptors. He's trying to do anything that might help, and the patient is beginning to experience more and more nocturnal manifestations, and now the patient is even having difficulty swallowing. This difficulty swallowing proved to be the result of severe esophagitis in this patient. So the severity of the patient's GERD is indicated by increasing episodes of heartburn and nocturnal episodes of heartburn, regurgitation that result in cough and these kind of things despite using 3 pillows. And here is a thing that you need to advise the patient properly. 3 pillows will not do anything. 10 pillows will not do anything. This is nothing compared to elevation of the head of the bed. This is the key word here. It's not more pillows, it is elevation. Put a block under the head of the bed. Question 4. Identify factors that may be contributing to the patient's symptoms. What might have contributed to the patient's symptoms? The hiatal hernia, of course, very important anatomical defect. Caffeine, alcohol, nicotine. Caffeine, alcohol, smoking will increase the manifestations of GERD. The use of verapamil in your patient's history. This patient has been using verapamil for hypertension. What's verapamil? It's a calcium channel blockers. What does any muscle need to contract, to be tight? It needs calcium. So the lower esophageal sphincter needs what? The lower esophageal sphincter is a muscle. So it needs calcium to be tight. When you block the calcium channel, when you block the calcium channels, the lower esophageal sphincter will not allow calcium in and it's going to be loose. That's why calcium channel blockers are among the factors that contribute to worsening the symptoms in GERD. And the patient is also significantly overweight. Obesity is one of the factors that contribute to the worsening of GERD. Question 6. What non-pharmacologic therapies or lifestyle modifications might be advised? Well, this patient has a lot to do. Raising the head of the bed instead of using pillows, and losing weight and reducing the use of caffeine, alcohol, and nicotine. Question 8. What are the therapeutic options available, and what if symptoms kept recurring? Now, this patient was not improved on H2 blockers, or H2 blockers seem to be not efficiently working. So the first choice after that is going to be what? Proton pump inhibitors. And as a matter of fact, now the guidelines are, the recommendations are, for treating GERD, it is proton pump inhibitors. So let me be clear here. No H2 blockers for treating GERD. No ranitidine, no famotidine for treating GERD. The treatment of GERD is proton pump inhibitors, amiprazole, and all of them have the same efficacy. Well, if the patient did not improve on proton pump inhibitors and you're still sure that it is GERD, not anything else. Now, if the patient's symptoms relapse after discontinuing the proton pump inhibitor, he might be treated with continuous or intermittent courses of proton pump inhibitors. Keep giving this patient proton pump inhibitors. Very rarely we might think of surgery. It's no longer done nowadays because of the efficacy of PPIs in treating GERD.